Well, to reward the faithful, shall we go ahead and get started? We have a straightforward lecture this morning on urinary tract infections, followed by a more complicated one on sexually transmitted diseases. Any questions from the previous lectures? Hearing no questions, we will proceed. Urinary tract infections are common, mainly a disease of women until the older years. As you can see, it's a big business, 7 million office visits a year, a lot of hospitalizations. Up to half of all women will have a UTI at some point during their lives. Most of these are uncomplicated. Some are complicated. Complications generally related to fairly obvious predisposing causes as shown here. These slides, two panels, show in the crosshatch areas the incidence of UTIs in men, and in the solid line, UTI in women. For some reason, in early childhood, in the neonatal period, little boys tend to have more UTIs than little girls. The probable explanation being that little boys may have some anatomic problems. The point is that thereafter, until the years of prostatism, UTI is almost exclusively a condition of women. I was once giving this lecture and someone in the back row said, "What is prostatism?" I said, "Well, it's like this. You begin to wake up in the middle of the night, to go to the bathroom, and you stand there and the world is entirely dark and quiet. This starts to happen night after night. And you begin to ask yourself, who am I? Why am I here?" So it's a male midlife crisis. But as we can see here at the top are asymptomatic bacteriuria, and at the bottom are symptomatic urinary tract infections. And if you go into schools, and we'll talk about little preschoolers and girls will have often positive urine cultures, but not boys. Then with sexual activity, so-called honeymoon cystitis, girls will develop UTI, women will develop UTI, and then as prostatism sets in, you'll see a lot of bacteriuria and UTI in men. Right, right. I'm sorry, I've got it the reverse. It's the reverse. I've got the legend on page 3. It's the reverse. Clinically apparent is the upper panel, and asymptomatic bacteriuria is the lower panel. We're going to look at some terms that are thrown around. Urinary tract infection simply indicates the presence of bacteria or sometimes other organisms, mainly fungi, in bladder urine with or without evidence of disease. Significant bacteriuria was a term coined by Cass to indicate the presence of more than 10 to the 5 organisms per ml in urine. Going back to the old bacterial growth curve, it was found that if you look at the population for, say, 10 to the 0, 10 to the 3, 10 to the 4, 10 to the 5, 10 to the 6, etc., that the results of urine cultures tend to be bimodal. A lot of people up here with 0, and then it goes down like that, and then it goes like this. So the point is that very few people have urinary bacteriuria between 10 to the 3 and 10 to the 4. The idea is that with fewer than 10 to the 3 or 1,000 bacteria per ml, this is usually contamination, although it might be significant, as we'll see, whereas people who really have infected urinary tracts tend to have say, 10 to the 6th or 10 to the 7th. So 10 to the 5 was found to be a cutoff point. So you'll see in clinical medicine every day, you will see urine cultures greater than 10 to the 5, greater than 100,000 colonies per ml, or colony-forming units per ml. Why do we call them colony-forming units rather than colonies per ml? Well, the bugs can stick together. You might have two of them stuck together and they'll form one colony on the plate. They reported out as CFU, colony-forming units per ml. So that's the term significant bacteriuria. Asymptomatic bacteriuria simply means that you have significant bacteriuria without symptoms. Then we get into pyelonephritis. And pyelonephritis, either acute or chronic, is really a clinical diagnosis. Acute pyelonephritis is really fever with back pain and significant bacteriuria. Clinicians talk about upper versus lower UTI. Upper UTI is simply above the level of the bladder. Because a lot of people will have symptoms of burning on urination, increased frequency and urgency of urination, but not have significant bacteriuria, the term urethral syndrome was coined. And this is a spectrum of things ranging from herpes simplex might do it to various organisms, mycoplasma and others have been looked at. A lot of these people simply have 10 to the 3 bacteria in the urethra. Here we have a kidney with a lot of small round cells, and this lesion was often called chronic pyelonephritis at autopsy. Here you have one with fibrosis, and pathologists would call this chronic pyelonephritis at autopsy. When that was done, it was found that, my gosh, chronic pyelonephritis at autopsy, based on lots of small round cells, lymphocytes, and scarring in the kidney, was equally common in women and men, according to the pathologist. The clinicians said, wait, this is not what we're seeing clinically. We see clinically with UTI, we see 1, 2, 3, 4, 5, 6, 7, 8, 9 women to every man with this disease. So we think there's something wrong about what you're calling chronic pyelonephritis, and it turns out it was. So to call chronic pyelonephritis at autopsy or on a surgical specimen, you really do need to correlate the gross anatomy with the microscopic anatomy. And the gross anatomy consists of these pits on the kidney overlooking areas of calyceal dilatation because pyelonephritis tends to be a skip disease in the kidney. So what you might have an area of normal cortex with a delicate calyces, and then you'll have a scar overlying an area of calyceal dilatation like that. And in that thin scar, you'll see changes here that would be consistent with chronic pyelonephritis, but not diagnostic of it without the gross correlation. This shows small round cells, fibrosis, and also what organ could you mistake this bit of kidney for in your histology? Lung wouldn't be my first guess. How about thyroid? Catherine got it? Yeah, thyroid change. This slide, which is upside down, shows a normal pelvic-calyceal system here and a diseased one here with late uptake of the diet. So UTI, again, finding microorganisms in bladder urine with or without evidence of disease or symptoms. Significant bacteriuria, finding them greater than 10 to the 5 CFU per ml. Good for screening purposes. As it turns out, and this is a major point, People with acute pyelonephritis, people who are sick, can have lower counts. The reason is that, kind of referring back to the bacterial growth curve, if bacteria descend from the kidney to the bladder and you give them time to grow up in the bladder, they're going to grow up to greater than 10 to the 5. They'll eventually probably grow up to 10 to the 9. Well, urine may not be quite as good as the broth media, so I can't say that for sure. They'll grow up. But let's say you have active pyelonephritis, a few bugs spill down here, and then you void pretty soon, and you don't let them sit around in the bladder, you may have a smaller count. Okay? So that the rule is good, but if you have symptoms, lower counts may be important, and that kind of takes you back to Bayes' theorem again and pretest probability. Follow me? Asymptomatic bacteriuria, significant bacteriuria without clinical symptoms or other abnormal findings, and all this is in your text. Acute pyelonephritis is a clinical syndrome with fever, flank pain, and tenderness, often with constitutional symptoms such as nausea and vomiting, white cell casts in the urine, bacteriuria. Or you might define it as the histologic findings thereof, although a few of these people, of course, will come to biopsy. Chronic pyelonephritis, long-standing infection associated with active bacterial growth or the residuum of lesions caused by such infection. Chronic interstitial nephritis was another term coined to denote kidney disease with histologic changes resembling chronic pyelo, but without evidence of infection. Chronic interstitial nephritis. Upper UTI, lower UTI, in terms of relationship to the bladder, and the urethral syndrome we've already defined. So we've gone over those terms. And you can see those terms the rest of your life or until the paradigm changes. Pyuria, presence of pus in the urine, which might or might not be caused by UTI. You can have white cells in the urine from other reasons. Today in clinical medicine there's a leukocyte esterase nitrite test which tests for both pus and bacteria. How common is asymptomatic bacteriuria? That is, if we went out into the audience here and got all of you to void, where would you fit on this x-axis? How common is asymptomatic bacteriuria? And point of the slide is that if you just put a catheter in the bladder and then take it out, there's about a 2% chance that you will induce asymptomatic significant bacteriuria. If you go to an internist's office and culture everybody in the waiting room, 5%. If you go to an obstetrician's office with people about getting ready to deliver, 10%. In hypertension, it goes up. Current thinking, as far as I can tell, seems to be that it's thought to be a result and not a cause of hypertension. Patients with diabetes have more UTI. And then, as you're beginning to get into obstructive symptoms, the simplest case being cystocele in a woman who's had babies and so on, the incidence begins to go up fairly dramatically. And as you start getting people with kidney stones and people who've gone to urologists, you will see a lot of bacteriuria. With greater degrees of obstruction, congenital urologic disease, 57%. Hydronephrosis. What is hydronephrosis? Do you have that in pathology? Hydronephrosis is, we take this here, kidney, and we put an obstruction somewhere, and this ureter becomes dramatically dilated, as does the pelvis, putting a lot of pressure on that kidney. That kidney's going to die if it's not, obstruction's not relieved. Hydronephrosis, very common. An indwelling catheter, if you just put a catheter in the bladder and leave it connected to the outside world, bacteria will get up there. So screening for asymptomatic bacteriuria in adults is currently felt to have little value except in pregnancy and before urologic surgery. In pregnancy, there's a large body of data that is a high risk of people with asymptomatic bacteriuria developing acute pyelonephritis during their pregnancy, and more controversial literature suggesting an increased risk of fetal complications. And before urologic surgery, you can almost guarantee that if you have bacteria in your bladder, you're going to become septic after the surgery. And indeed, I'll talk a little bit about that in the lecture in sepsis. A little bit about bacteriology. The thing that's really neat about urinary tract infections, as opposed to, say, pneumonias and most of the other things that we see, is it is easy to get good bacteriology, right? All you got to do is to whiz and be relatively careful about it, right? A little more tricky in women than men for obvious reasons, but easy to get that good, clean specimen. You have to process the specimen fairly carefully. You should note that the doubling time of common bacteria is about 20 minutes. So assuming that my Starbucks coffee cup was a urine specimen, you wouldn't want to just leave that out on the counter and go do a whole lot of other things, right, before you did something with it. You'd want to put it in the ice box. Some contaminants in urine are shown here. Anaerobic bacteria are seldom really pathogens in the urinary tract. These organisms might be colonizers, but not really pathogens. Any growth is significant if the specimen is collected from a normally sterile site. That is, by direct bladder puncture, for example. Sometimes you can go in and do a suprapubic stick. However, because the urethra may have a flora, any growth from voided culture is not necessarily true. Now this, and I'd like to put in an exam question about this many years. In pyelonephritis, the greater than 10 to the 5 CFU per ml rule tends to break down. It's noted up to 20% of young women with acute pyelo have lower counts. Also, in catheterized patients in whom specimens were obtained directly from the bladder, between 10 to the 2 and 10 to the 4 CFUs per ml might be important. And the reason for this, of course, you're draining the bladder and not letting the bacteria multiply in the bladder. Patients with uncomplicated infection almost invariably have a single organism. If you see 3 bacteria or more in a urine specimen, sometimes the lab will throw that out as contamination. In a complicated infection, say you have somebody who has a permanent suprapubic cystoscopy, which is sometimes necessary for people with bad disease of the outflow tract, and the urologists kind of throw in the towel, and so they put in a chronic suprapubic drain, you're going to have a bunch of bacteria in your urine all the time. If you look at an unspun midstream urine, and we were trained to do this. I'm not sure that it's done as much as it used to be now that we're getting away from the microscope so much, to my lamentation. If you took unspun urine, just put a drop on the stage and looked at it, put a cover slip on it, looked at it under high dry, if in the average field you saw one brick-shaped structure floating across, that had a good correlation with more than 10 to the 5. That rule tends to hold up in looking at sputum and other things. If you see bacteria on a gram stain of sputum, that means there's probably going to be more than 10 to the 5 of them there. So that has a high positive predictive value for significant bacteriuria. On the other hand, if you look at spun urine, spin it down and discard the supernatant and take the sediment and put it on a stain, on a stage, Absence of bacteria makes significant bacteriuria very unlikely. That is a high negative predictive value. Pyuria usually, but not always, accompanies acute symptomatic urinary tract infection. So that covers a little bit of the bacteriology. Any questions there? Now we get into the etiology of acute urinary tract infection. This is nearly always an aerobic gram-negative rod disease, with E. coli the most common culprit. In people who have first-time UTIs, E. coli sensitive to all antibiotics, or pan-sensitive E. coli will be the most common organism. You should know, and this may show up on exams, that one of the coagulase-negative staphylococci, Staphylococcus saprophyticus, may cause UTIs. And that can be important because usually you see coagulase-negative staph in the urine, you say that's got to be contamination. But there's this one coagulase-negative staph saprophyticus, which interestingly is the only uropathogen that I know of that has a seasonal disposition. It tends to occur in the summer. Staph saprophyticus. Anaerobes, pyogenic cocci, and viruses are rare causes of community-acquired UTI. As you get into the hospital and get sick people with pressure of antibiotics, E. coli remains the most common organism, but you begin to see a lot of the other gram-negative rods, the Enterobacteriaceae and Pseudomonas ace, Pseudomonas aeruginosa. I read a nice statement in a textbook one time that Pseudomonas is seldom seen in the urine in a patient who hasn't been to a urologist. And you start to see in a VA hospital, particularly like here, with old men sitting around with their catheters, World War II vets. You start to see serratia and providentia and a lot of resistant gram-negative rods, and that's almost axiomatic. Give me a patient's age and urine culture result, and I can tell you something about that patient. I'd be very surprised. Enterococci, the common gram-positive coccus in the gut, sometimes causes UTI in otherwise healthy young women, etc., but it's usually seen in obstructive uropathy. Then as you get, again, selective pressure of antibiotics, you get yeast, Candida albicans, etc., etc. Why, from all of this, why is it not such a good idea to try to stamp out asymptomatic E. coli bacteriuria in somebody who's in a nursing home? This question comes up, and a lot of administrators and auditors don't seem to understand this. Why is that not such a hot idea? Yeah, the person's got, it's not so much the E. coli that's the culprit, it's some anatomic reason that they've got this UTI. They got a cystocele, prostatism, So if you treat this thing aggressively, you're just going to invite more difficult to treat critters to get up in there. So why don't we wait and just treat this person when they become symptomatic? And a mistake that I see sometimes made is you'll see an older person in a nursing home who will have a fever and they'll have a UTI and says, aha, the UTI is the cause of fever. Well, I think you have to look elsewhere. It might be the UTI, but you need to look elsewhere as well. So that's an important point there. Another important point that shows up on exams a lot is to know that certain organisms split urea, cause the urine to be alkaline, and lead to stones. And of these, Proteus mirabilis is the most common cause. This leads to struvite calculi, and I thought I had a good picture of a staghorn calculus, but this can cause what's called a staghorn calculus, where you see on a plain film of the abdomen, you would see a great big calculus. I didn't draw this very well at all, but it would actually form a nice cast of the pelvocalyceal system. it would outline the pelvic-calyceal system. So that kidney is gone unless you can somehow break that thing up and get it out. So alkaline urine, Proteus mirabilis, but also certain other organisms, struvite stones. UTI in children, newborn infants, about 1% more in little boys. Preschool children, you start to culture them, 10 to 20 times more common in girls. If you go into a school and culture little girls, on a given day, slightly more than 1 in 100 will have, lo and behold, bacteria in the urine. And these little girls, and we'll talk about them a little bit more, these little girls tend to have something anatomically different about their epithelial cells and their introitus, which is genetic. And their little girls are more apt to have asymptomatic bacteriuria. These little girls are more apt to develop honeymoon cystitis and pyelonephritis in pregnancy too. We'll talk about that in a little bit. UTI in adults, bacteriuria increases with the age and with sexual activity. One strategy for preventing UTI in women is to give half a Bactrim tablet or a quinolone or something after sex. A study was done in probably medical school couples. They had volunteers sleeping on a research ward, and after sex the women would jump up and void, and then they would jump up again and void in 4 hours, and then in the morning. And sure enough, it was found that sex causes many women to develop asymptomatic bacteriuria, which is usually flushed out of the system, but occasionally will go on to lead to symptomatic UTI. In men, bacteriuria is rare before the age of 50, but, as indicated, as a corollary, calls for more aggressive evaluation than in women. In other words, in a man, women have been, over the years, probably abused in terms of too many cystoscopies. Men, on the other hand, although a little bit of literature now suggests it may be more permissible for men to have UTI, as a general rule, UTI in a man indicates that he's got some obstructive problem and needs to go to see a wee-wee doctor. The mention of the schoolgirls gets into the idea of bacterial adherence by a specific adhesin receptor interaction. You would predict. For the bacteria part, E. coli, some of them stick better than others, and these tend to have these Velcro-like projections or pili or fimbriae on them. And there has been, the latest thing that I have seen on this indicates that there's a specific gal, alpha 4 gal adhesion factor on the fimbrial polymer. However, E. coli strains probably have more than one bacterial virulence factor. This shows a Proteus strain with these long fimbriae, and you can just see how that thing would want to stick to you, right? Like Velcro. Want to stick and not get off. This is a simple experiment of the sort that's been done. It turns out it's something genetically related to your epithelial cells in general, and you can do this experiment by scraping off buccal epithelial cells as well as scraping off vaginal epithelial cells or epithelial cells around the urethra. And what you do in this experiment is just to scrape off a bunch of buccal epithelial cells, put them in the bottom of a test tube, and put in some saline and wash them and so on and so forth. And then throw in some E. coli. Wash them a few times, shake it all up on your Vortex Genie mixer, and spin it down, and then throw off the supernatant and look under the microscope. And in most people, the E. coli will wash off. They won't stick. But in some people, they will stick. This shows a squamous epithelial cell with E. coli attached all over it. And so this tells you that some people just have these receptors on their cells that attract bacteria. Host defenses have been looked at in some detail. Urine has some antibacterial properties. They're not wonderfully antibacterial properties. the osmolalities, having a high osmolality or a very, very low one, high urea concentration. A lot has been made of the pH. To acidify the urine is looked at as discouraging UTI, whereas if you make it alkaline, you encourage UTI. So this is a basis for saying drink lots of orange juice, and different things are given to sometimes acidify the urine. Cranberry juice may have a role, but it's been shown that you would have to drink a large amount of cranberry juice for it really to work. People have tried bacterial interference, give you some good E. coli or something that would not tend to cause disease. Host has some anti-adherence mechanisms. Won't go into that very much. And, of course, the urinary immunoglobulins and so on and so forth. For all the work that's done in this field, I'm not sure how important any of this is, except for the mechanical flushing of voiding. Seems to be the best. Get them out. Best defense. Most UTIs are ascending. That is, you get prior colonization around the urethra, and then bacteria go up the urethra to the bladder, and then from the bladder they go up against the flow to the kidney. Most UTIs are ascending. And this affords an obvious explanation for why UTI is less common in men than in women until the years of prostatism. The only advantage of being male that I know of is you have a longer urethra. Otherwise, women are superior, correct? Descending infection is important for a few organisms, such as staph and candida. That is, bacteria coming hematogeneously to the kidney and then going down. Have any of you ever been involved, done experiments with the bug and had the problem of maintaining the virulence of the bug? The standard way to do that is, tell me, Gene, is this still standard? I know when I was in their age, I did some scientific experiments and with E. coli, and what we did was to take a rat. What I did to keep my E. coli valid was take a rat and ligate the rat's ureter, then inject my E. coli into the rat's blood, and come back and culture from the rat's kidney. Right? Because otherwise, if you just left the organism on the shelf in the icebox, it might lose its virulence. But this helped it retain its virulence. So the idea being that by tying the bacteria got in the urine and would have just, by the descending route, would have just been flushed on out without any consequence. But by creating a urinary obstruction, it created a culture medium. So occasionally, if you have obstruction, it can do that. Staph does have the ability. We talked about staph causing abscesses. Staph aureus, when it gets in the blood, has the ability to cause an abscess in the kidney. So that's important. And Candida albicans can as well. Staph aureus is not really a uropathogen, but it does spill into the urine from a bloodstream infection. Lower UTI, 99.9% of a bladder inoculum experimentally is promptly eliminated by voiding. Possible biological explanations for frequency of UTI in some women include deficient antibodies and biochemical differences in the receptors on their urothelial cells. And as noted here, upper UTI, obstruction and reflux. Also, modal bacteria can go up against the flow of urine, and in pregnancy especially, gram-negative bacteria can inhibit ureteral peristalsis. The renal medulla, once bacteria get into the kidney offers very little effective defense. As indicated, the renal medulla has been likened to an immunologic desert, with its low pH and high osmolality interfere with white cell function, can also interfere with antibody and complement function. And the different ways to try to localize upper versus lower UTIs, and the urologists will get into this. It can be, we'll catheterize both ureters, for example, and that may be very useful. Other tests, such as the antibody-coated bacteria tests, have not panned out particularly well. In clinical practice, I think that this usually sorts itself out fairly well. Fever and flank pain indicate upper UTI, pyelonephritis, fever and flank pain. What do we mean by flank pain? We'll have you come down here to demonstrate it, since you're having spoken up for the superiority of women. We'll.
I was just saying that.
What? We refer to the CVA, which is a costovertebral angle, with the idea, and you'll see that tenderness, costovertebral angle, the idea that the kidney sits right about there. So turning her around, I'll just put my hand here. It's kind of bad form to hit her like that, you know. So I'll put my hand here and ask if that hurts. Doesn't, so you can go back to your seat. Thank you. So CVA tenderness, fever and CVA tenderness, so that's big, and we do that routinely on examination. Sometimes it's hard to tell. Acute, uncomplicated cystitis in young women. Acute dysuria in young women usually indicates cystitis, the urethral syndrome, or vaginitis. Sometimes it's hard to ferret those out. It's burning on urination, so you have to do that on clinical grounds. Acute cystitis, usually sudden onset, multiple symptoms, pyuria and hematuria. You want to make sure that a person doesn't have, say, herpes simplex or something like that. Subclinical involvement of the kidney may be more common than we've generally thought. The bacteriology, again, most of these are going to be E. coli. We talked about Staphylococcus saprophyticus, occasionally other organisms. E. coli in young women, acute cystitis, E. coli. And in recent years, we've tended to emphasize that an abbreviated workup and a short course of antibiotics usually works. Acute pyelonephritis in young women is largely a clinical diagnosis, fever and flank pain. Prognosis is nearly always very good. About 20% will have positive blood cultures. This would be acute pyelonephritis in a rare autopsy specimen showing these leukocytes all over the kidney and in the tubules. And this would be white cells in a tubule, and microscopically in the urine, this would show up as a cast. Presence of such a cast strongly suggests pyelonephritis. This is pus coming out of the kidney. This would be the CT scan showing pyelonephritis. Recurrent UTIs in women, between 20 and 25% of women have frequent UTIs, usually due to reinfection with a different E. coli strain. It's possible to type E. coli, and you could save them and see to what extent this is relapse versus infection. Usually these are women with some genetic reason on it. I got on a talk show one time where I was hooked up with doctors around the country talking about UTI, and somebody out in Idaho said, I think it's pantyhose or something. There are all kinds of theories about, why some women get UTIs and others don't. But there probably are genetic factors. There may be others. Use of a diaphragm and spermicide for contraception may. Bacteriuria in pregnancy, instance of acute pyelonephritis. This slide makes the point that treating bacteriuria is very beneficial in preventing pyelonephritis in pregnancy. Complicated UTIs, by definition, people with predisposing problems. Again, the spectrum of organisms is skewed toward hard-to-treat bacteria. Pseudomonas, enterococci tend to be a marker of some obstructive uropathy situation, yeast, and so on and so forth. This fellow had an acute perinephric abscess. It had 1.5 liters of Staph aureus drained out of him. Catheter-associated UTIs in the hospital. It's a really big problem, very, very common. Female sex duration, etc. And we emphasize the point of never breaking that seal between the catheter and the drainage tube. You need a specimen, you aspirate it from the catheter, keeping that bag in a dependent position. When the patient's transported to the hospital, don't just put the bag up on the patient's tummy, for example. So that's pyelonephritis. And prostatitis, we won't say much about, except it's bad, you don't want it. And we'll break until 5 till 10, and then we'll talk about sexually transmitted diseases, what Mama didn't tell you.